Welcome back to IVF webinars tonight. It's wonderful to be here once again. As always, we are back in September. We had a bit of a summer break, but of course, we are back with amazing topics. And this one is definitely a little bit controversial, a little bit intriguing, but I'm glad that we will be talking about this tonight. And as always, we have a special guest with us. Some of you might be already familiar. Dr. Uliana has been our expert many times before. And this is Dr. Uliana Dorofeyeva, and she's the medical director at OVOGENE, which is a outside bank, of course, but also she's the director of international corporations at IVMED, located in Ukraine, Kiev. So welcome back, Dr. Uliana. It's wonderful to have you here. And this topic tonight that you have prepared the presentation on, it's about intralipid infusions. And of course, as always, Dr. Uliana will start explaining when it's recommended, how it's done, and of course, afterwards, your favorite part will start. It will be Q&A session. Don't forget to put the questions in the chat section so that Dr. Uliana can answer them for you. Remember, you can always put them in the chat section during the presentation or afterwards, and I'm sure Dr. Uliana will be happy to get some answers for you. Okay. And before we start, let me just mention that my IVF Answers is a part of European Fertility Society, and European Fertility Society has been very busy. We are working on many different projects right now. There will be a fertility care awards that we are preparing, and it's going to be definitely interesting for all the patients. We have experts, big experts of panel of experts that will be choosing not only best care clinic, for example, when it comes to care, but also some other initiatives. So it's going to be definitely interesting. I can only encourage you to have a look at European Fertility Society website, and you can find all the details right there as well. And I guess we can go ahead with our presentation. Let's get to it, okay? I'm really looking forward to it. Okay, Dr. Uliana, ready?
Yes, absolutely. Thank you, Carolina, for the kind introduction. And as you know, it's always my pleasure to support all initiatives, especially such great initiatives of my IVF Answers. And yes, we are going to talk about intralipid infusions, indications, and the prospects. But also, we will start from the unexplained infertility as a topic which leads us to the immunological infertility and the need of thinking about immune treatment and prescribing of any kind of the medications connected to the immune treatment. So we were used to talk about unexplained infertility as an infertility which was idiopathic in the sense that the cause remains unknown even after an infertility workup is done. However, for the many years, we've been increasing the list of the tests which we are able to perform prior to the successful IVF treatment or prior to any IVF treatment. And we've started with a very simple one, like a semen analysis, assessment of the ovulation, assessment of the fallopian tubes, etc. However, right now and today, we are going to talk about what much wider list of the tests which may be done, which some of them are still not for the clinical use and the interventions. Some of them are really discussable. Some of them are not practiced in some locations in some countries or by some of the doctors, and they need to be confirmed, and they are still used as a clinical trials. However, many of them are really effective. So if we are talking about the definition of unexplained infertility, we should mention that it's unsustainable and highly subjective, because it depends on which tests have been performed, which tests have been allowed or are allowed in the country where the patient is going to be treated, what is the quality of those tests, and who performed the evaluation. So that's why if we are talking about diagnostic workup, sometimes it may be incomplete. And if we would like to say about the basis for successful treatment, we all know and we all agree that we need to take care about the uterus, and we are checking uterus carefully, performing evaluation, not just like an ultrasound and hysteroscopy, but also some other tests like an endometrial receptivity, evaluating other conditions, preparing the endometrial lining to have as maximum receptive endometrium as possible. We pay attention for the embryo in order to be like, probably nobody is talking about these three embryos today, and we all are talking about blastocysts, and even more we would like to work with the blastocysts which have been checked and evaluated and confirmed as being euploid blastocysts. There are different methods. However, this is not all the basis for the successful treatment, and we need to remember that between all the others, we also have immunological factors which are playing quite important role for the implantation and the further development of fetuses. We have a genetic factors which needs to be assessed prior to the successful treatment, and also factors related to the oocyte or the embryo itself. Also, there are many of those, and by evaluating and taking care of everything in advance, we may get into the most successful treatment which is possible, and shortage the interval from the starting the treatment until the pregnancy is achieved. So we are talking about multifactorial causes of the infertility. And if we talk about the couple who had, and probably many of the patients today have been trying already one or few cycles before, and these cycles were unsuccessful or they ended up with miscarriage. So probably you agree that the doctors, they were able to find several factors of why this could happen. And if we are talking about immunological infertility, we need to talk about autoimmune diseases. And these diseases are those which relate individuals' immune system. And the immune system is responsible for defending the body from being attacked by infectious agents such as viruses, bacteria, and some others. And those patients who suffer from autoimmune diseases, their immune system is damaged a little bit, and it reacts improperly by attacking and destroying healthy body cells and tissues. And this situation can also occur during the pregnancy. So women with immune disorders are at increased risk of the repeated miscarriages or other fertility disorders. And the mechanism of the functioning of our immune system is by recognizing the body's own structures, thanks to the matrix of compatibility complex. These are the complex of the cells, mainly T lymphocytes and B lymphocytes and different cells, which recognize that this structure, that structure, the tissue, the cells, etc., by production of antibodies by white blood cells or the lymphocytes, the structure of foreign bodies by natural killer cells, and we are going to talk more about natural killer cells today, and establishing the mechanism of tolerance during the pregnancy so that the mother's immune system identify the baby foreign body and reject it. So, with the autoimmune disease, the immune system still is unable to differentiate what is proper from what is foreign. So, it creates the antibodies to attack the body's own tissues. And if we are talking about pregnancy, so it attacks the embryo and destroys it before the development and before the embryo has a strong supportive system as a placenta after the third trimester. And mainly, we are talking about autoimmune diseases and immunological infertility. So we need to pay the most attention for the first trimester and the early stages of the implantation. But continue about the autoimmune diseases. Currently, we know about more than 80 autoimmune diseases, and more common they are in women than in men. Depending on the organ or the system of the body which is affected, autoimmune diseases can be classified into the target for one organ, like a celiac disease, for example, or the systemic, which are mostly common for the causes of the immunological infertility. And the systemic autoimmune diseases or immune changes can affect any organ or affect multiple organs and the system at once. They occur mainly because of the genetic predisposition for the development of the autoimmune diseases, um, or the environmental factors can also play the role, and also they are dedicated for some specific races and the ethnic groups. So if we are talking about the implantation, so this is the such a crucial period in the IVF treatment. Once we went already through the preparation, the stimulation of the ovaries, receiving the oocytes, or deciding about other processes for receiving the oocyte as an oocyte donation, for example. We created the embryos, we checked the embryos in the best way possible, and we came into the embryo maternal crosstalk after transferring the embryos into the uterus. And this is the time when the blastocyst apposition and adhesion should take place. It is very important to talk during that period about the window of implantation, because this is another condition which is not properly assessed, not always properly assessed. And also we know more about some other factors, like an reaction of the endometrium into the good quality and the poorer quality embryos, as well as the development of some other factors like KIR receptors and genotypes of the embryo. However, if we would like to assess if the mother's body is baby friendly, we need to perform some tests, and we need to check the immune factors. And the immune factors are responsible, for example, for the spiral endometrial arterias development, for the adhesion and the proper implantation. And it's already confirmed, so it was quite controversial, and still in some publications it is, but more and more evidence is given to the fact that the INCA cells, they are playing the role for the fact of the recurrent miscarriages, and they are defined as 3 successive miscarriages if the patient is aged less than 35 years, or 2 miscarriages if the patient is aged over 35. And repeated IVF failure is defined as 2 or more unsuccessful fresh IVF cycles. However, this could be fresh embryo transfers. We are talking, of course, for the cycles ended with the embryo transfer. Of course, we need to think and we need to remember about the fact either these are own oocytes used and the embryos have been tested for genetic status, so we are talking about the best quality embryos and potentially euploid embryos, or we don't know that information, as well as other assessment as a window of implantation, if that has been done or it hasn't been done prior to the treatment. Now we know that the INCA cells are divided into the uterine and the peripheral blood NK cells. We've been working with both, and for many years, until the development of the testing of the uterine and NK cells, we've been working with the peripheral blood, like a Chicago bloods and the general immunogram assessment for the patients. And based on the evaluation of the NK cells or finding the other factors of the changes, and also, which was the most important, understanding the previous treatments and the outcomes and the factors which potentially could play the role that treatment or that history of that specific couple could have immunological issues, we decided to go ahead with the immunological treatment. Of course, right now we have more probabilities of checking either peripheral blood cells and the uterine blood cells by performing endometrial scratching and the evaluation of the endometrial tissue during the window of implantation. So the immune system is critical in establishing the relationship between the mother and the fetus in order to allow both to develop and flourish. So the immune testing, which we've been performing and currently perform now, these are immunological tests and cell level autologous antibodies, HLA, but also uterine biopsy for evaluation the uterine NK cells. And the most common immunological treatment are IVIG, intralipids, and prednisolone. Also, we've developed the strategy already, and we started to test the key receptors and fetal HLA-C genes. However, the scientific society is still keeping that subject as a controversial and says that this is too early for the clinical interventions. However, for the patients with really problematic medical history and previous anamnesis who've been tested or been recommended to assess their HLA-C genotype and key receptors, quite often for the donor oocyte selection, we are performing that test as well. In terms of the treatments, so the intralipids, they deactivate natural killer cells in the woman's body, which may prevent embryos from implanting and growing properly in the uterus. Initial studies show comparable efficiency for the activation of the natural killer cells and the pregnancy rate compared to the IVIG. Intralipids are well tolerated by patients with few side effects which potentially can be found after treatment with the IVIG, as they are created synthetically, unlike the IVIG, which is the blood product. It is a mixture of the high calorific natural fats containing soybean oil, egg yolk, phospholipid, glyceride, and water. In Ukraine, we have the ability to offer real IVIG, the proper IVIG medications. We have a factory which produces the IVIG, and intravenous immunoglobulin is a product made of antibodies, which we also inject intravenously. And the antibodies are the protein which the human body makes to help to fight infections. Each antibody fits like a clock to the key for every foreign substance which can get into the body of the human. Over the course of the life, human body makes thousands of different antibodies as it is exposed to the different infections organism and human body considers to be foreign. It's prepared from the blood, from the donor's blood, and each bottle of the IVIG consists more than 300 donated albumins, but it is super concentrated and very diverse collection of antibodies against many possible infection organisms and which the body can encounter. And risks and the side effects of the IVIG. Before using that, it is recommended to perform certain blood tests, keeping the patient well hydrated, giving the infusions more slowly, dividing a large dose into the several smaller doses, which are given over several days. And we recommend to inject the IVIG 2-3 days prior to the embryo transfer date, or sometimes we inject this on the embryo transfer date prior to the embryo transfer itself. The explanation is that in any case, implantation is happening within next 24 hours after the embryo transfer was done, but the IVIG starts to act immediately after it is injected. So we are not losing the pharmacological effect from making the infusion on a day of the embryo transfer prior to it. For some patients, we may recommend to prescribe pain-relieving medications. However, these are very rare cases. The risks of getting the viral infection from IVIG is considered exceedingly low. We've never heard about, and there is any publication about this to happen, as the methods used to purify the IVIG will destroy all the agents. And this treatment causes temporary changes in the human body. So if we are talking about long-term risks by prescribing the intravenous immunoglobulins, there are any. And the activities of the medication is held for 21-28 days. And for these specific patients who really need the IVIG, and we've seen the repeated miscarriages, and there are indications for prescribing this. Mostly we perform either the injection just once during the embryo transfer day, or we repeat the injections every 21 to 28 days during the first trimester of the pregnancy. For very rare cases, and during my practical experience for many years, we've had about up to 10 patients, just 10 patients, for whom we prescribed together with the immunologist the IVIG until the 35 weeks of the pregnancy. And this was absolutely needed in terms of the condition. So as soon as we stopped the IVIG, there was a risk of the miscarriages, hematomas, tonuses, and the risk of the early deliveries in more second and the third trimester of the pregnancy. So these patients, they should be specifically identified. So we need to perform screening for those patients. We need to consider all the medical history and all the aspects of their infertility, understanding that infertility could be and is multifactorial. So all the factors needs to be considered. In order to be the best prepared, we would recommend to transfer euploid blastocyst in the cycles when we are going to perform immunological treatments such as IVIG or intralipids. But also remember about the fact that this needs to be done in the window of implantation. So if that screening has not been performed prior to that cycle or that embryo transfer, we would really recommend to do so. And the time frame during which endometrium has maximum sensitivity for the embryo implantation, we call it window of implantation. We assess the window of implantation by performing electronic microscopy test, which is done in the endometrial preparation cycle with the artificial cycle, like was the agonist pre-treatment injection in the cycle before, then estrogens starting on the beginning of the next cycle, and progesterone since the endometrium lining is well prepared, receptive, and is more than 7.5 millimeters. And then the pipal endometrial aspiration on day 6, 8, and 10 from starting the progesterone administration. and scanning electronic microscopy of endometrial specimens to assess the presence and the maturity of the pinopodias. This test is not the same as the test, which probably has been performed for some of you. And we can do this as well. So we are sending the samples to the laboratories which can do error. However, the results and the further decisions which are made based on the electronic microscopy assessment are very similar as to the endometrial receptivity tests. And the embryo transfer with respect to the window of implantation is called personalized embryo transfer. And for the groups for whom we performed this test and then the further embryo transfer, we had over 70% of those patients with multiple repetitive failures before as being successful. Some of those patients, of course, they also went through the immunological treatment and testing and assessment, and it is very hard to define the specific group of the patients to say how the immunological treatment was effective, because it was given according to the medical indications to the different patients in the different age groups, with the different factors of the infertility, different male factors, uterine, etc., etc. However, we in our center, we may say that we are believers in the immunological factors of infertility, and if they are present, we would definitely assess them and check prior to the embryo transfer. Also, what is recommended is to check the morphology for the oocytes and the embryos. And we keep talking about the genetic status of the oocyte, which is giving us 70% of the probability of creating euploid and healthy blastocyst, which will give us the higher chance of successful implantation. As well, what is available right now, this is the carrier screening, which is more and more common both for the couples and also for those who is planning oocyte donation. And we call the oocytes which are genetically tested and also for which we recommend to perform or we perform NGS testing to guarantee their euploidity and have the highest probability of the quality embryos as genetically tested oocyte technique. And we need to remember about the rate of the abnormalities, which is connected to the age of the patient. So if we are talking about patients in their advanced maternal age, looking into these percentages, we need to understand the fact that once we are going to perform the treatment, logical treatment for the patient, we need to make sure that the embryo which we are going to use in that treatment cycle will be with the probability of getting implanted. So 70% for the embryos being morphologically blastocyst for the patients in their age between 40 to 42 are aneuploid. So it is recommended to test those embryos prior to be used. Also, we are talking about development of the non-invasive PGT and artificial intelligence for prediction of the highest quality embryos. So maybe in the nearest future, we will be able to avoid the biopsies and the invasive interactions into the embryos. However, so far, the classic method is to do the biopsy and perform the genetic testing as we've used to do it already by the NGS testing, either for the oocytes or for the embryos. So we believe into the what has been said by the Dr. Norbert Glacher, that unexplained infertility should not exist. And generally, it means that the physician failed to find the true cause of the infertility of the patient. So in our center, including the immunological infertility, intralipid testing, IVI treatment, IVIG, prednisolone, if we are talking about, and other medications and the assessment of and the treatment, including other factors which potentially may play the role for the successful implantation and the shortage of the period for the successful pregnancy. We believe into immunological infertility and the fact that this needs to be checked. So to conclude, the diagnosis of the unexplained infertility is unsustainable and highly subjective. There are different treatment options which may be recommended in IVF to achieve a goal of the parenthood. There are various implantation factors which needs to be considered prior to the embryo transfer. Second opinion is recommended due to specific limits in the countries and the practices which are currently used in the clinics. And immunological infertility is an important part of general infertility problems and has huge developments right now. Thank you for your attention, and I will be happy to get your questions in Q&A session. I will try to answer all of them, of course.
And as always, it's been an amazing, amazing presentation with lots and lots of details. Thanks so much, Dr. Uliana. You never disappoint. This is always very thoroughly explained. So thanks a lot for that. And well, now it is your time to ask your questions. So don't forget, if you have any, go ahead, type those in the chat section, and Dr. Uliana will answer them for you. And the first question is up right here. It's a bit, yeah, here it is, sorry. How long do intralipids take to work?
So in comparison to the medications given like pills, which are still existing, intravenous, either intralipids or immunoglobulins are acting immediately, meaning as soon as this medication is getting into the blood, it gets the NK cells, and the immune system in general works differently. So it takes out from the central organs all the NK cells. So this is the mechanism of action. And all these NK cells, they are going into the periphery to fight with the structure, with the molecules which came together with these medications. So we are getting the central organs, which includes also the uterus, being free from the high levels of the NK cells. So this is how the mechanism works right now, how it is explained. And it's valid for 21 to 28 days. It's very individual, and we need to consider each patient individually, and the treatment should be individualized in terms of prescribing, the dosage, the frequency of the immunoglobulins. It's easier to predict for the patients who've been treated with any kind of immunological treatment before that treatment cycle. However, it's easily just for those who've been unsuccessful. And it's hard to say, but for some patients, we are losing their pregnancies just because we haven't repeated the IVIG in this certain period of time. And it happens sometimes because, for example, like these medications are not used in some countries. And if patients visited Ukraine for the treatment and they've got their injection, however, they fly back home and there is no possibility to repeat it after the positive pregnancy achieved, and sometimes even the heartbeat is confirmed, we need to repeat it. But if there is no opportunity, so the result could be different. So then for the next pregnancy, they will come, or we will think about how to get the medications in their country or where to go. So it's very temporary action for the immune system by receiving the immunological treatment, and it needs to be checked, and we need to remember about this.
All right. Thanks so much, Elisa, for your very first question. Of course, Dr. Liana, for your thorough answer. Definitely, it's not an easy thing to do then, if especially if someone has to go out of Ukraine in such case. Thanks so much for explaining. And what pregnancy week is it recommended to stop intralipids, and usually how often they need to be administered?
So they needs to be administered every 3 to 4 weeks. This is what we know from the mechanism of action. And for most of the patient, I would say for 80%, we stop prescribing IVIG and intralipids after the first injection and as soon as the clinical pregnancy is confirmed. So 6 weeks of the pregnancy, first ultrasound scan, if they see the heartbeat and if there is no hematomas, tonuses. However, sometimes it really starts very rapidly, and this is very common for the immunological issues that today everything was fine. We've checked the pregnancy on the ultrasound, and in 2-3 days there was intense heavy bleeding, and that's it. So that's why for most of the patients we recommend to keep injections until the first trimester of the pregnancy is completed. So first trimester of the pregnancy, this is the term when the placenta is developing and developed properly. So placenta is responsible for this crosstalk between the mother's body and the fetus, and it supports a lot the fetus development once it is completely developed. So the first trimester, this is the term when we can think about, and mostly we stop the IVIG treatment. So since the embryo transfer until the end of the first trimester, we have 3, sometimes 4 injections of the intralipids every 3 to 4 weeks.
Wonderful. Again, thanks so much for yet another interesting question and your help with that. More questions are coming in. Next one, another interesting question. Is there any exam to evaluate the effect of intralipids? Do you consider normal any special range of NK cells, blood NK or UNK?
Mm-hmm. Yeah, it's a good question. And as I said during the presentation, we still rely in both tests for many patients, and this is easily to get tested for the peripheral NK cells. And but we are considering not only result. Of course, all patients are tested. However, we also consider the previous anamnesis of the patient, and discussing the treatment plan with the patient. We go ahead with immunological treatment, immunological testing and treatment, or some other way of the treatment, and then the strategy for the treatment cycle. So and we know and we agree that uterine NK cells are more certain and more predictive in terms of the treatment, and we need to be based mostly on those tests. However, our previous experience, which we have for many years already, prior to the fact, until we started to analyze uterine NK cells, also the peripheral blood, but mostly the anamnesis works well in terms to decide and being successful with the treatment. So there is, we do not perform any confirmation that NK cells immunological treatment worked. The best confirmation for this is the clinical pregnancy and the development of the pregnancy.
Again, many thanks for yet another question and, of course, for your help. And another question is right here. So, would you consider hematoma in early pregnancy a consequence of immunological factor?
Um, I cannot say that always hematoma is the prediction of the immunological infertility. However, if we are talking about proper early pregnancy development, we should avoid having hematomas. And if there are, they are present, and especially for the patients for whom we initiated immunological treatment, if we see any risks for the first trimester development, we would consider repeating IVIG treatment or any immunological treatment just to prevent risk of losing that pregnancy.
All right. Thanks so much again, of course, for the explanation. And at least for now, we need to wait a bit and see if there are more questions. Remember that if you don't have more questions, we will be slowly finishing, but don't hesitate. If there's anything else that you would like to ask, do it now. And of course, I know that Dr. Uliana, in her presentation, explained everything, so that's understandable. But of course, we definitely want to make sure that we have been able to help you out with anything that's on your mind. And someone is typing, so as always, we just need to wait a bit and see. Have a look at the other question.
Yeah.
If not,
Let's wait until that time. I just would like to mention that
Mhm.
immunological developments, like the evaluation of the immune system activity, especially now during the COVID time, it's very, very interesting for the scientists. And it was always interesting for the reproductive specialists, like the immunologists, endocrinologists, reproductive doctors, etc. And even there are some developments for the immune contraception right now, but still they are it's on the level of the clinical trials, and this is the direction. So probably we will talk and we will get more and more activities, actions, and decisions, medical decisions, and the evidence here in the immune system response. But so far, the evidence is low, again, because not all the locations, not all the countries are using these medications, and there are not so many publications. And even those, as I mentioned, to say clearly for which group of the patients just immunological treatment worked, it's really hard, because we did not only something what was different from the previous treatment was not only immunological treatment, but many other factors which were assessed, evaluated, and then controlled or avoided. So that's why immunological treatment is very interesting, and we keep working with our immunologist, because I'm as a gynecologist and reproductive doctor, is not fully aware of all the mechanism and actions. But if we have a complicated patient who needs the assessment of the immunologist, of course, we do it together.
All right. Thank you so much for explaining and adding that. Definitely something that we should all remember. And more questions, as you can see, are coming in. So the question is, how much is each intralipid infusion in Ukraine?
It depends on the dosage and the volume of the infusion which is recommended. However, the average dosage of 10% IVIG would be 200, again, depends on the patient, but from 200 to 500 milliliters. And the cost would be, we need to double check with coordinators, definitely. I'm afraid to be mistaken, but I think it's about 800 euros. But it's better to write us and to get this confirmed by the email, please.
That's understandable, of course. So thanks a lot. And remember, you can use the link. You will be redirected to it right after we finish, and that way you can get in touch with Dr. Liana, her team. I'm sure they will be able to provide more details. Okay, and what causes an imbalance of natural killer cells?
Um, it's very uh, like we need to talk about each case individually for the causes, because NK cells can be evaluated in any autoimmune disorder which may be founded in the human. And as we said, we are talking about more than 80, and 80 these are just known diseases. And I'm sure that with development we will get into more factors. So it's very hard question to explain just a simple cause.
Of course, that's understandable. Very general question, but of course, thank you so much still for this. Okay, next question is: what kind of dose of prednisolone would you prescribe for high cytokines?
Thanks, Emily. We use between 4 to 40 milligram per day of prednisolone. However, the dose, individual dose, is the individual prescription. So, and also high cytokines, we need to talk specifically about each case.
All right, thank you. And Emily has added one more question. Do you recommend medical mushrooms for immune issues? Example, Messima, Coriolus.
No, Emily, unfortunately, I have no experience in that. So still, even the medications which we are talking about right now, they have no evidence. And if we are talking about up to date and the coherent database, etc., so they are not level A as a recommendation. But considering the risks and the benefits, we decide to recommend those. However, these medications, I don't know them and I have no practice to use them.
But of course, thank you so much. And there's a thank you from Emily as well. And next question is up. Do you use enoxaparin in these cases?
Yes, for the any kind of heparins, like clexane or even low dosage aspirin, we check previously the factors of the coagulation and thrombotic factors, and after that we decide about prescription of that medications in the cycle. And if yes, as well as prednisolone, we're starting them in the beginning together with the estrogen during the cycle preparation of the endometrium.
Okay, again, thanks so much for that. Another question might be our final question. Okay, so let's have a look. I was told at 8 weeks that the embryo, not PGS tested, was measuring 5 days behind in terms of size. Would you consider that a consequence of immunological factor or more likely a problem with the embryo itself?
The question would be, what was the development of that pregnancy? Either that was scary, or the embryo stopped its development. Have you done the histological evaluation to consider also the genetics of the embryo? If that was a miscarriage or ablation, for example? Like, if for outside, but like it
Dr.
wasn't an issue.
Dr. Uliana, okay, it's really hard to. Right now, we cannot hear you very well. The sound is really breaking at the minute. Um, Maybe try to switch off your camera for a minute, and hopefully that will help. Okay, because we didn't hear you properly, I'm afraid. Okay, and can you repeat what you said about this question?
So I
Sorry, we cannot hear you right now very well. Not sure what
more
happened. Sorry, still cannot hear you.
Fine, I will try to.
Dr. Uliana, can you hear me now? Because we cannot hear you right now at this point. So let's give it a second, okay? Sure, Dr. Uliana, maybe you can refresh. That's my only idea, as we cannot hear you right now. Not sure if you can hear me. I will try to reach Dr. Liana. Okay, so please bear with us. And if you have more questions, go ahead, type those in right now. Okay, we will try to answer as many as we can. And of course, we will be finishing. And yes, I think that Dr. Uliana disappeared, but don't worry, she'll be back. So if you have more questions, go ahead to do it. Okay, let's wait and let's see. Dr. Uliana should be here in a minute, I hope. So Liana should be here in a second. I already see she's in the room, so I hope that it will be possible. So you can still ask her questions. Okay. Yes. Hi, Dr. Liana. Welcome back.
I'm sorry. I had to change the provider for the internet.
Yeah. So basically, if you can just repeat the answer to this, I know it's a bit confusing, but if you can repeat what you have said earlier, because we didn't hear you properly.
Yeah, that's fine. So I
Thank
was
you.
saying that it would be good to get some answers into the questions. For example, like what was the age of the patient one, like age of the oocyte from each the embryo from which the embryo was created, and what 34, yes, thank you. And what was the development of that pregnancy? So it's ended up with the miscarriage, or there was a possibility to check the genetic status of that embryo or not. However, more likely it looks for the embryo itself factors than for the immunological factors, because immunological factors, they mostly play their role on the implantation itself. So either this is very early term of the pregnancy or the absence of the implantation in general. Yeah, if you are waiting for the next scan to be the measurements, even for the few days difference, they could happen. And they are quite common and depend on equipment factor, even the human factor sometimes, as we are talking about millimeters. So let's hope the embryo will be appropriate to the term during the next scan and everything will be fine.
All right. Thanks so much. And of course, fingers crossed, as always. We are definitely hoping that it's going to have a good result as well. Okay, next question is up. And Thank you very much from the patient for you, Dr. Uliana, for answering. Thanks so much. Is biochemical pregnancy linked to immunological issue?
Again, mostly yes. However, the factor of the embryon should be checked. Like if this is an issue with the euploid embryo, so definitely this is an issue of the implantation. And if this is an issue of the implantation, we should be looking for the immunological factors here.
Thanks so much indeed. And someone is typing again. Let's have a look whether it's a thank you or we have another question. And there is a thank you. And I guess we will be slowly going to an end. So thanks so much, everyone, for your questions. You never disappoint. There are very interesting and intriguing questions at times as well. And thanks for that, because that makes it a lot more interesting as well. And I'm sure Dr. Liana always appreciates, like, if we have those kind of questions, not too easy, not too difficult, right? So thanks a lot.
Absolutely. Thank you for all the questions and for your activities and being here and spending that time together with me and with IVF Answers. Thanks a lot and all
Thanks
the best.
indeed. Thanks so much. And of course, remember, it has been recorded. You will have a chance to watch this. And of course, I just also want to mention that if you don't know already, we will be back on Monday. We are starting our new IVF webinar series, simply because it's going to be focused on success stories, real cases, different various cases, of course, from low AMH to recurrent pregnancy loss, and also other factors like genetics, but we will focus only on real patient cases. And of course, we have more and more experts from different clinics, from different angles. It's going to be talked about, and I'm sure it's going to be interesting. So I can only invite you to join us at 6 p.m. UK time on Monday. And of course, Dr. Uliana, it's always a pleasure. I know we will have more events soon. Looking forward to them. Thanks so much. Enjoy your evening, everyone. And well, I do hope to see you here on Monday as well. Thanks. Take
Thanks.
care.
Goodbye.
Bye
Bye.
bye.